Okay, let's shift gears to diagnosis. Our mission is to sort of turn you, the listener, into a detective. We've combed through the clinical guidelines, the scoring tables, all the protocols. We want to walk through that whole investigation.
Moving from those fuzzy, vague suspicions to the hard evidence.
To the smoking gun.
I like that. We're building a case. And we should start at the crime scene, the clinical presentation.
Okay, let's start with the lungs then. Pulmonary embolism. The classic symptom is shortness of breath. But, I mean, short of breath is probably the most common complaint in any hospital.
It absolutely is.
So how do you tell a deadly clot from, a panic attack or just being out of shape?
That is the million-dollar question. The textbook will tell you. Sudden onset, unexplained breathlessness. And sure, if a healthy 20-year-old suddenly starts gasping for air, of course alarm bells are going to ring, but that's the easy case.
Right.
The masquerader usually strikes people who already have a reason to be breathless.
And this was the idea in the reading that really grabbed me, the concept of the occult clue.
Exactly. So think about a patient with heart failure or COPD. They're always a little breathless, right? Yeah. They come into the ER, their breathing is worse, and the doctor thinks, okay, it's a heart failure flare-up.
Or pneumonia.
Or pneumonia. So they treat them with diuretics to pull fluid off, or they start antibiotics.
Standard of care. You treat what you see.
Right. But here's the clue. Failure to improve. You're giving the standard treatment, but the patient isn't turning the corner. The pneumonia just isn't clearing up. The heart failure patient is still gasping for air.
So that gap between the treatment and the response, that's where the PE is hiding.
That's the camouflage. It's using the patient's existing illness to hide itself. It's really terrifying when you think about it. The takeaway is, if the patient isn't following the script, you have to stop and ask, is there a clot under all of this?
Okay, so let's move downstream to the source, the legs, DVT.
Yeah.
I think most people have this mental picture of a big, red-hot, swollen leg.
And that definitely happens. But again, the masquerader prefers subtlety. A lot of the time, it just starts as a cramp, just a nagging pain in the lower calf.
Which feels exactly like a Charlie horse.
Yep.
Or maybe you pulled something at the gym.
It feels identical. But there's a nuance in the timeline. A gym cramp usually hits hard and then it fades. A DVT cramp is persistent. It's this low-grade annoyance that just gets worse over days. It won't quit.
Now, the notes mentioned a severe end of the spectrum for DVT, a term that sounded like a spell from Harry Potter.
Yeah.
It's like Mesia ceruleus dolens.
It really does. It sounds like Latin magic. It translates to something like painful blue edema. And this is a massive DVT. It's not just a little blockage. It's a total occlusion of all the venous return. The leg just balloons up, it turns blue or purple because the blood is trapped, and it's excruciatingly painful.
That sounds like a surgical emergency.
It is. You're at risk of losing the leg. But thankfully, that's rare. Most of the time, you're dealing with that subtle calf cramp. Which brings us to the problem of the mimics. Because not every calf cramp is a clot.
Right. We have to clear the innocent bystanders. The first one on the list was a ruptured Baker's cyst.
Ah, classic fake out. A Baker's cyst is just a fluid-filled sac behind your knee. If it bursts, all that fluid runs down your calf muscles, and it hurts a lot. But the key distinction is usually the speed.
Speed.
Yeah, a ruptured cyst is sudden. Patients will often say, I felt a pop, or it felt like I was shot in the leg. A DVT is almost never that instant. It's a slow build.
So sudden snap is probably a cyst. Gradual ache is more likely a clot, as a rule of thumb.
Generally speaking, yes.
What about the anatomical mimic, this May-Thurner syndrome?
This is a fascinating one. And it's really important because it affects a specific group, usually young women. It's basically a plumbing issue. In your pelvis, the right iliac artery crosses over the left iliac vein.
So the artery is literally sitting on top of the vein.
Exactly. And because the artery is high pressure and it's pulsating, it squishes the vein against the spine. It creates a traffic jam, and that leads to swelling. But, and this is the key, specifically in the left leg.
So a young woman with unexplained recurrent left leg swelling, you have to think May-Thurner.
You have to. It's a structural problem, not just a random clot.
Okay, before we leave the what else could it be phase, we have to talk about this really bizarre category. The non-thrombotic embolisms. Things traveling to the lungs that are not blood.
Right. And this is where the detective work really relies on context. Because a CT scan might just show a blockage, but it won't necessarily tell you what the blockage is made of.
The list was wild. Cement.
Bone cement. Yeah, it can happen after orthopedic surgery, like a total knee or a hip replacement. The cement they use can sometimes leak into the veins, harden, and then travel to the lungs.
That is a terrible complication. What about fat embolism?
This is one you watch for after major trauma, like a car crash where someone breaks their femur. The femur is full of fatty bone marrow. If it breaks, these little globules of fat can get into the bloodstream and just shower the lungs.
And that causes a specific set of symptoms.
It does. It causes a very specific syndrome: shortness of breath, confusion, and a rash.
So, context is king. Broke a femur, think fat. Hip replacement, think cement. In labor.
Amniotic fluid embolism. Very, very rare, but absolutely catastrophic. It happens when fetal material enters the maternal bloodstream.
Okay, so we've interviewed the patient, we have our suspicions, but we can't just throw everyone into a CT scanner. It's expensive, there's radiation, the dye can hurt the kidneys. We need a way to filter the suspects.
We need a probability filter. We need to turn our gut feeling into an actual number. And that's where the scoring systems come in. The most famous one is the Wells score.
I looked at the criteria. It really feels like a checklist for danger. You get points for active cancer, for being bedridden, for having a swollen leg.
It's a way of quantifying risk. But there's one line item in the Wells score that I think is just the most brilliant piece of clinical logic. It's worth 3 points in the PE score, which is huge.
This is the alternative diagnosis one.
Yes. The question is an alternative diagnosis less likely than PE?
That forces the doctor to actually stop and think. You can't just tick boxes. You have to actively consider, could this be pneumonia or a muscle strain?
Exactly. And if you can't find a good alternative, if the story just doesn't fit anything else, you get massive points towards PE. It rewards critical thinking.
So let's say we tally the points. If the score is high, we assume they're guilty and move to imaging. But what if the score is low? What if we're on the fence?
Then we use one of the most misunderstood tools in modern medicine, the D-dimer test.
Right. I feel like a lot of people, and honestly, maybe some doctors, treat the D-dimer as a simple yes-no switch. High means clot, low means you're safe.
And that is such a dangerous oversimplification. We need to explain what D-dimer actually is. When your body forms a clot, it uses a protein called fibrin to make a mesh, like a net, to catch blood cells.
So fibrin is the web that holds the whole clot together.
Correct. But your body is constantly remodeling. It's always building up and breaking down these little nets. When the body chops up that fibrin net to dissolve a clot, it releases little fragments. Those fragments are D-dimers.
So if your D-dimer is high, it means your body's breaking down a clot somewhere.
Yes. But, and this is a huge but, clotting is part of the body's general repair process.
Right.
So D-dimer goes up if you have an infection, it goes up if you have cancer, it goes up if you're pregnant, it goes up if you just had surgery.
So high D-dimer just tells you something is happening.
Exactly. It's incredibly sensitive. It rarely misses a clot, but it's terribly nonspecific. It cries wolf all the time.
So why do we even use it?
And we use it for its negative predictive value. Because it's so sensitive, if the D-dimer is normal, if it's low, you can be about 99% sure there is no clot. It's a rule-out test.
So you use it to send people home, not to admit
Yeah,
them.
precisely. But there was this snag with the test. As we age, our bodies just generate a little more inflammation, a little more background clotting. A healthy 80-year-old has a naturally higher D-dimer than a 20-year-old.
But for years, we used the same cutoff for everyone.
Right.
So something like 500.
We did. And think about the consequence. You have an 80-year-old grandmother. She's fine, maybe a little achy. Her D-dimer comes back at 600. The limit is 500. So purely based on that number, she gets sent for a massive CT scan.
She gets radiation she doesn't need, contrast dye that might hurt her kidneys, spends hours in the ER, all for a false alarm.
Exactly. It was bad medicine. So the research community came up with the age-adjusted D-dimer. This is a total game changer.
The math is super simple, right? And if you're over 50, you just multiply your age by 10.
That's it. So for that 80-year-old grandmother, her new cutoff isn't 500, it's 800.
So her level of 600 is now considered normal. She goes home, no scan.
It saves resources, it saves anxiety, and it saves kidneys. It's such a simple tweak, but it drastically improves how we handle elderly patients.
Okay, so we've scored them, we D-dimered them, and let's say they failed the tests. The risk is high. Now we need a picture. We need to see the villain.
Time for imaging. For the legs, it's the venous ultrasound. And the technique here is shockingly low-tech. It relies on a property of veins. Veins are thin-walled, they're floppy.
Right, unlike arteries, which are these thick muscular tubes.
So if you take an ultrasound probe and you press down on a normal thigh, the vein should just flatten out. It disappears. We call this the wink test. It just winks closed.
If there's a clot in there.
A clot is solid. It's like a sausage stuck in the tube. You press down, and the vein refuses to collapse. It just stays open. That loss of compressibility is the diagnosis. You don't even have to see the blood flow. If it doesn't squish, it's a clot.
That is just amazingly simple. Now, for the lungs, it's a bit more high-tech. The CT pulmonary angiography.
The CTPA, this is the gold standard. We inject contrast dye, timing it perfectly so the dye is lighting up the pulmonary arteries just as the scanner is spinning. You get this high-res 3D map of the lung plumbing.
So you can see the clot. But the source material mentioned that the CT gives us more than just a yes or no. It gives us a prognosis.
This is crucial. We aren't just looking for the clot, we're looking at the heart's reaction to the clot, specifically the right ventricle.
Can we break that down? Why is the right ventricle the victim here?
So the heart has two sides. The left ventricle is the bodybuilder. It has to pump blood to the entire body against high pressure. It's thick, it's strong. The right ventricle is, frankly, the wimp of the heart.
Okay.
It only has to push blood next door to the lungs. It's thin-walled. It's used to a low-pressure life.
So when a PE happens?
A PE is a blockade. Suddenly, the pressure in the lungs skyrockets. The right ventricle is trying to push against a closed door. It can't handle it. It starts to fail. It stretches out.
So on the CT scan, if you see the right ventricle ballooning up,
if the right ventricle is bigger than the left ventricle, that is a really bad sign. It's called RV strain. It tells us the heart is failing, and it significantly increases the risk that the patient will die in the next 30 days.
so that patient needs aggressive care. ICU, maybe clot-busting drugs.
Exactly. The picture completely changes the treatment plan.
Now, there is an alternative to the CT, the VQ scan. This feels a bit old school.
It is, but it's elegant. It solves the problem of the contrast dye. If a patient has kidney failure, dye can shut their kidneys down completely, so we can't use the CP on them.
So how does VQ work?
V stands for ventilation, so air. Q stands for perfusion, so blood. You interpret the scan by looking for a mismatch.
You want to see if the air matches the blood?
In a healthy lung, where air goes, blood goes. Simple. In a PE, the airways are totally open, so the ventilation scan looks normal, the radioactive gas gets everywhere.
But the blood is blocked.
Right, the clot stops the blood. So on the perfusion scan, you see this big, empty, whole, cold spot.
Air gets in, blood doesn't. That mismatch is the signature of a PE.
It's a great physiologic test. It's just a little harder to interpret than a nice, clear CT picture.
We've covered the core investigation. But this, the deep dive. We promise some deep cuts. The stuff you whip out on rounds to impress people.
Let's do it.
Let's talk about the subtle signs in other tests, like the ECG. There's a classic pattern every med student memorizes. S1Q3T3.
Ah, yes. Sounds like a droid from Star Wars.
It does. It refers to specific waves in specific leads. An S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3. If you see that, you've nailed it, right?
You wish. It's actually a trap. While S1Q3T3 is specific, meaning if you see it, it really does suggest PE. It is incredibly insensitive. Only about 20% of PE patients have it.
So if you don't see it, it means absolutely nothing.
Nothing.
So if we stop staring at leads IN3, where does the data tell us to look?
We need to shift our gaze. We need to look at the precordial leads.
Okay, specifically.
V1 through V4.
And this is where the statistical most common abnormality actually lives. We're talking about T-wave inversions in those anterior leads.
Right. And to really get why this is the superior marker, we have to move beyond just pattern recognition and, look at the anatomy.
It's basically geography. V1 through V4 are the anterior leads, but more importantly, they're sitting right on top of the right ventricle.
Precisely. And that is the mechanism. A pulmonary embolism is fundamentally a problem of right ventricular strain. The clot obstructs the flow, the pressure just skyrockets, and the RV has to push against this immense resistance.
So the RV starts to dilate. It's suffering from demand ischemia.
And V1 through V4 have the front row seats to that whole disaster. Those T-wave inversions are the direct electrical translation of the RV struggling. When you see new inversions in those right-sided leads, you are seeing the physiological footprint of the PE.
It's a much more logical approach than just hunting for S1Q3T3. You're actually looking for the organ dysfunction itself. Now, this doesn't happen in isolation, though. The rate is the other half of this, right?
Yes, you cannot ignore the context. Sinus tachycardia is the backdrop. The heart is racing to compensate for that decreased output.
So the clinical picture we should be scanning for isn't a complex acronym in the limb leads. It's a tachycardic patient with new T-wave inversions in V1 through V4.
That combination sinus tach plus anterior T-wave inversion, That is the screaming red flag for RV strain. If you see that, you don't need S1Q3T3 to tell you the patient is in trouble.
What about the chest x-ray? I feel like everyone gets a chest x-ray first thing.
They do, and this is the scariest part for a novice. The most common X-ray finding in a deadly pulmonary embolism is a completely normal X-ray.
Because the clot is inside the blood vessel, and x-rays don't see inside blood vessels?
Exactly. X-rays see fluid, bone, and air, not clots. But historically, some really eagle-eyed radiologists have spotted some rare signs.
Like Westermarck's sign.
Yeah, Westermarck's is fascinating. Because the blood flow is blocked, the vessels downstream kind of collapse, so that part of the lung looks too black. It's called focal oligemia.
Like an Hampton's hump?
That's a little wedge-shaped shadow at the edge of the lung. That's lung tissue actually dying because it lost its blood supply, a pulmonary infarction. But again, these are super rare. Don't rely on them.
Okay, one last deep cut. The echo, the ultrasound of the heart itself. Is there a specific move the heart makes when it has a PE?
Yes. This is for the true connoisseurs. It's called McConnell's sign. Remember we said the right ventricle is struggling?
And stretching out, yeah.
Well, usually the free wall of the ventricle just stops moving. It's stunned. But the very tip of the heart, the apex, is sort of shared with the strong left ventricle, so the apex gets dragged along for the ride.
So the wall is frozen, but the tip is bouncing.
It's hyperactive. It looks like it's winking at you. That specific pattern-stunned wall, bouncing apex, that's McConnell's sign. It's highly specific for PE.
It's amazing the body just leaves these breadcrumbs if you know where to look.
That's the job, assembling the puzzle.
So let's bring it all back together. We've gone deep. How do we summarize the integrated approach for everyone listening?
Okay. Step 1, suspicion. Don't dismiss that unexplained breathlessness, especially in patients who aren't improving with standard treatment. Step 2, risk stratify. Use the Wells score. And subtract points if it really looks like something else.
If they're low risk.
Use the D-dimer to rule it out. And please, use the age-adjusted D-dimer if they're over 50. Don't overstand grandma.
And if they're high risk, or that D-dimer comes back positive,
go to imaging. CTPA is the gold standard, but don't forget the VQ scan for your kidney patients. And when you're looking at that scan, look for the signs of right heart strain. That's what kills people.
it's a whole process.
Yeah.
But it has to be, because the masquerader's just so good at hiding. So we're looking at a topic today that seems like it should be settled science, but the more you dig into the clinical management of DVT, the more you realize, take your blood thinners it's barely scratching the surface.
It really is. We're talking deep venous thrombosis, but specifically how the playbook completely changes depending on where that clot is.
From the arm all the way down to the calf.
Exactly. And the sources we're diving into, you know, the Garfield VTE registry, the ATTRACT trial, they all highlight one thing: location dictates everything.
Yeah, that upper extremity data was the first thing that really jumped out at me.
Okay.
I mean, you usually associate DVT with, like, long flights or leg issues.
Sure.
But clots in the arm are climbing. And the sources pin that almost entirely on the rise of PICC lines, peripherally inserted central catheters.
It's a direct correlation. It's almost 1-to-1. As PICC usage goes up in hospitals, so does upper extremity thrombosis.
But it's more than just catheters cause clots. It's about the hardware itself, right? The actual physics of it.
That's the nuance. It really comes down to the engineering of your selection.
So the guidance is pretty explicit. Use single lumen lines, avoid the double or triples. But the size, measured in French, seems to be the real critical variable here.
It is. Ideally, you want a 4 French catheter. That's tiny, about 1.3 millimeters. The moment you step up to a 5 or, a 6 French, you completely change the hemodynamics.
You're just taking up too much space in the vein.
Way too much. You're slowing down blood flow around the catheter.
And that stasis is the trigger for thrombosis.
That's the trigger. So you want the smallest possible profile to keep that blood moving.
Okay, so if we flip the script from hardware risks in the arm down to the leg, the whole patient profile changes completely.
It does. I mean, you look at the Garfield VT data for isolated calf DVT, and these are not your typical high-risk patients.
Right, they're less likely to have active cancer or a prior history of clots.
Exactly. These are patients who have largely had recent surgery or some kind of leg trauma.
Which is what I found so counterintuitive. You have a patient who seems, lower risk systemically, and the clot is isolated. And yet the data shows we are just hammering these people with anticoagulants.
Oh, the treatment is surprisingly aggressive. The registry showed that nearly half of these patients were kept on anticoagulation for at least a year.
A full year for an isolated calf clot. That just feels like we might be over-treating, especially with the bleeding risks.
Well, that's the debate, isn't it? I think clinicians are clearly worried about the clot propagating, moving up the leg.
Sure, but a year.
Yeah.
It suggests we might be treating the scan, not the patient.
That's a valid concern.
So speaking of aggressive treatment, let's talk about the open vein hypothesis. This is the idea of going in and physically dissolving the clot.
Right, catheter-directed therapy. And on paper, it makes perfect sense. You get a massive clot, it sits there, it wrecks the valves in the vein.
And that leads to post-thrombotic syndrome, the chronic swelling, the pain.
The ulcers, yeah. So the hypothesis is get the clot out early, save the valves, and you prevent the syndrome. Simple.
But then the Atricti trial came along
Yeah.
and really complicated that simple narrative.
It was a major reality check. They tested this aggressive approach against just standard blood thinners on almost 700 patients, and after 2 years,
No different.
no overall reduction in post-thrombotic syndrome. So for the average patient, the extra risk and cost of that procedure just didn't pay off.
But there was that one subgroup, right? The location thing again?
Yeah.
The iliofemoral cases?
Yes. This comes right back to our main theme. If the clot was really high up, in that iliofemoral segment, there was a trend toward benefit.
So the sheer size of the clot in those bigger veins makes a difference.
It seems to. Aggressively clearing out a massive clot up there seems to matter more than for a clot that's lower down in the femoral vein.
Okay, so high up, maybe clear it out. Lower down,
Yeah.
meds are probably enough. Which brings us to the most low-tech intervention of all, compression stockings.
Right. And there's a big myth we need to bust here.
The idea that they prevent post-thrombotic syndrome.
Exactly. For years, we've told people to wear these tight 30, 40 millimilli HG stockings, but the data just doesn't support prescribing them to an asymptomatic patient for prevention.
So they're purely for symptom management. If you have swelling, if you have discomfort, wear them.
Yes. If it hurts, they help. If it doesn't, you aren't saving your veins by forcing yourself into them.
And you have to remember to replace them, right? They wear out.
They do. They lose elasticity. You need new ones every 3 to 6 months. Clot in the lung, that's the scary part.
That's what we really want to unpack today. We've got a stack of clinical guidelines, a bunch of pharmacological protocols, and some really interesting data on risk stratification. Our mission really is to figure out why we treat that first patient with a pill and send them home, while the second patient might end up in the ICU. We want to decode that decision-making framework.
Exactly. We need to move away from the simple idea of there's a clot, give blood thinners. I mean, that's the kindergarten version.
Right.
We're going to do the grad school version today.
Okay, let's do it. Let's start with the basics, with categorization.
Yeah.
Because when I hear the term mass PE, which is, the scariest one, my brain immediately goes to size. I picture this huge clot.
Like a golf ball, yeah.
Exactly. Blocking the main artery.
Yeah.
But looking at the definitions here, it seems like size doesn't actually matter.
It's one of the biggest misconceptions, truly. You can have a huge clot burden, I mean, lots and lots of blockage. But if your heart is compensating well, it's not technically massive.
So what makes it massive then?
Hemodynamics, it's purely about stability. A massive or high-risk PE is defined by shock. It means the patient has persistent hypotension. We're talking a systolic blood pressure that's stuck under 90, or say a drop of 40 points from their baseline.
And that has to last for a while.
For at least 15 minutes, yeah.
So the patient is crashing.
They are on the edge of a cliff. The heart is failing to pump blood past that blockage, and the organs just aren't getting perfused. That is massive, and that means an immediate trip to the ICU.
Okay, that makes sense. If they're crashing, it's massive. But then we step down to submassive
Yeah.
or intermediate risk.
Yeah.
This feels like the gray zone. This is where mistakes could happen.
It's the danger zone.
The patient is stable, their blood pressure is fine, they might be chatting with you, so why are we so worried?
This is the danger zone precisely because they look okay on the outside, but inside, the engine is screaming. You see that strain on a CT scan or an echo, the RV looks huge. Or you see it in the blood work. You get elevated troponin, which means heart muscle cells are literally dying from the stress.
So, okay, the patient has normal blood pressure, but their right ventricle is fighting this losing battle.
And if it tires out, they crash. They become a massive PE right in front of you.
That's a much more vivid picture. The submassive patient is basically a ticking time bomb.
Correct. And then, surprisingly, you have the low-risk group. And the data here is just fascinating because, historically, if you had a PE, you were admitted, period.
Right, you don't send someone home with a potentially fatal lung condition.
Well, actually, Now we do. If a patient is stable, has no heart strain, normal enzymes, and they score low on these risk calculators, like the PC score.
Or the PSE, that's the Pulmonary Embolism Severity Index.
That's the one. And there's a simplified version, the SPECI, which is great. He looks at things like age, cancer history, heart rate, blood pressure, oxygen levels. If you score a 0 on that scale, your risk of dying in the next 30 days is almost negligible.
So these patients are basically treated
Yeah,
like they have a bad DVT. Just here's a prescription, go home, rest up.
pretty much. And that's a huge shift in mindset. It saves beds, it saves money, and it keeps patients out of the hospital where, they can catch other things.
Okay, so we've triaged them. We know who's crashing. We know who's going home. I want to zoom back in on that crashing patient, the massive PE, because the management here seems to go against every single instinct I have from watching medical dramas.
You mean the flu?
Yes. If someone has low blood pressure, the first rule is usually fill the tank. Hook up 2 large bore IVs and just open the saline wide. But the guidelines here are practically screaming, do not fluid overload.
It is completely counterintuitive, isn't it? But
Yeah.
you have to go back to the anatomy we just talked about.
The wimpy right ventricle.
Exactly. Remember, the RV is already ballooning out because it can't push blood past the clot.
Right.
If you dump a liter of saline into the veins, all that fluid just rushes to the right ventricle. It overfills it even more.
Okay, so it gets bigger. Why is that so bad?
Because the heart is enclosed in this strict, non-stretchy sac called the pericardium. There's limited real estate in there.
Right.
So if the right ventricle balloons out, it has nowhere to go except inward. It pushes the septum, the wall between the chambers, into the left ventricle.
It literally squashes the left side of the heart.
It bows right into it. We call it interventricular dependence. The left ventricle becomes D-shaped. It gets smaller, so it can't fill with blood.
If it can't fill, it can't pump.
It can't pump. So by giving fluids to fix the blood pressure, you actually choke off the cardiac output and you can kill the patient.
That is terrifying. It's a physiological trap.
Mm-hmm.
So if we can't use fluids, but the pressure is, say, 70/40,
Mm-hmm.
what do we do?
We use vasopressors, so drugs like norepinephrine to tighten up the blood vessels, boost the pressure without adding volume, and maybe we'll add dobutamine to help the heart squeeze harder.
But those are just Band-Aids.
They're total Band-Aids. We need to clear the blockage.
The clot busters.
Thrombolytics, systemic TPA.
This is the stuff that actively dissolves the clot, right? It's not
Right.
just a standard blood thinner.
Right, standard anticoagulants just stop new clots from forming. TPA is like pouring Drano down a clogged pipe. It dissolves the fibrin mesh holding the clot together. It works fast, it relieves that RV strain, and it restores blood flow.
But I'm guessing there's a big but. You don't give this to everyone.
It's a very high-stakes gamble. The standard dose is 100 milligrams over 2 hours, but the risk of a major bleed somewhere in the body is around 10%. And the one we really worry about, a bleed in the brain, an intracranial hemorrhage, is about 2 to 3%.
That's a 1 in 30, 1 in 50 chance of a disabling stroke.
Correct. So you are standing at the bedside, looking at a patient who is dying from the clot, and you have to decide, do I risk causing a brain bleed to save their heart? It is one of the toughest calls in medicine.
What if you can't use it? Let's say the patient just had brain surgery or was in a car accident. They're already at high risk of bleeding. Are they just out of luck?
No, and this is where technology has really advanced. We can go mechanical. We have catheter-directed therapy.
Snaking the tube up through the veins.
Exactly. An interventional radiologist or cardiologist guides a catheter right up to the clot in the lungs. They can use suction devices to physically suck the clot out, or they can use ultrasound waves to kind of loosen the clot while dripping a tiny, tiny dose of TPA directly onto it.
A localized strike instead of a systemic bomb.
Perfect analogy. Much lower bleeding risk. And for the absolute worst cases, we still have open surgery. Surgical embolectomy. It used to be a real Hail Mary pass.
Right.
But in experienced centers now, the outcomes are actually fantastic. They put the patient on bypass, open the pulmonary artery, and literally pull the clot out with forceps.
It's amazing we have those options. But okay, let's step back from that cliff edge.
Unfractionated heparin, or UFH. The mechanism is pretty straightforward, right? It binds antithrombin, speeds it up, stops thrombus formation.
Right, but the sources keep pointing to its short half-life as this major feature, not a bug.
Which seems counterintuitive, but I get it. If you have a patient who's unstable, maybe heading to surgery.
It absolutely is a feature. You need that. You need to be able to turn the dial up or down instantly. That short half-life gives you immediate command.
And when we do turn that dial up, the dosing is Well, it's practically burned into every resident's brain.
The old 80 and 18?
Yep, 80 units per kilo as a bolus, then an 18 units per kilo per hour infusion. The math is simple.
But the management, that's where the frustration comes in.
Yeah.
You're stuck in that constant loop of checking the APTT.
Aiming for that 60 to 80-second window.
Yeah, and that's what the articles call the monitoring trap.
Because the APTT, it's the standard, but it can be so noisy. And the protocols mention ditching it for certain patients.
You have to. If you've got a patient who's pregnant or has antiphospholipid syndrome, or you even just suspect heparin resistance,
The APTT is just not reliable.
it's not. The chromogenic anti-XI assay is far superior. It cuts through all that biological noise that messes up the APTT.
Speaking of biological noise, this was the part of the research that really surprised me. UFH isn't just an anticoagulant.
No, not at all. This is a massive point that gets overlooked. It has these pleiotropic effects.
It actually reduces inflammation.
It actively decreases systemic and local inflammation. Think about a septic patient. That's a huge potential therapeutic advantage that the newer, cleaner drugs just don't have.
But that messiness of UFH is exactly why we pushed for an upgrade, right? Which brings us to low molecular weight heparin.
The predictable upgrade.
Mm.
It's basically UFH that's been chopped up into smaller, more manageable fragments.
And smaller fragments means less drama.
Less drama. They don't bind as aggressively to plasma proteins or to the cells lining the blood vessels.
So you get much better bioavailability.
And a really, really predictable dose response. For the vast majority of patients, you don't need any lab monitoring at all.
Which is a huge convenience factor.
Huge. It frees up the entire clinical team.
Though the protocols do flag a couple of big exceptions where that predictability kind of fails.
Right. If your patient is markedly obese or has chronic kidney disease.
The standard math doesn't hold up.
It doesn't. And you're right back to needing labs again.
Okay, so that brings us to the most modern, almost sci-fi option, fondaparinux.
The synthetic specialist. It's an ultra-low molecular weight heparin, an anti-sacchinate pentasaccharide.
And the headline here is that it's synthesized in a lab.
Completely synthetic. It's the only one of the three not derived from animal products.
And because it's synthetic, that's the key to its biggest safety advantage, isn't it? The HIT issue.
It takes it completely off the table.
Mm-hmm.
Heparin-induced thrombocytopenia is an immune reaction. Since fondaparinux has no animal components, it simply cannot cause HIT.
And the workflow is even simpler than LMWH. A once-daily injection, and that's it.
Basically zero monitoring.
Unless
the kidneys are failing. It's cleared renally, so if you see that creatinine start to climb, you have to adjust that dose downward. Most patients, the vast majority, are not crashing. They just need anticoagulation. This is the bread and butter.
And this is where the landscape has really, really
You're
shifted.
talking about the rise of the DOACs, the direct oral anticoagulants, apixaban, rivaroxaban. It seems like warfarin, the old standby, is mostly retired for this.
For PE, yes. DOACs are the new standard of care. They're just easier. Fixed dose, no constant blood monitoring, no dietary restrictions. You can eat all the kale and spinach you want.
But looking at the protocols, it's not just take 2 and call me in the morning.
Yeah.
There's some serious nuance in how you start these drugs.
Oh, absolutely. This is where I see mistakes happen all the time. You cannot just write a script for the maintenance dose. You have to load the patient.
Talk us through that. Why the loading dose?
In that acute phase, that first week or so, the clot burden is high, and the body is in this prothrombotic state. It wants to clot more.
Right.
So for apixaban, which is Eliquis, you give 10 milligrams twice a day for 7 days. That's a high dose. Then you drop to 5. For rivaroxaban Xarelto, it's 15 milligrams twice a day for 3 weeks.
So hit it hard, then back off.
Ah.
That seems straightforward. But then I look at dabigatran and edoxaban, and the instructions are totally different. It says parenteral lead-in required. What's that?
This is the tricky part. For those 2 drugs, the big clinical trials were designed differently. They required the patient to be on an injectable blood thinner like heparin or LMWH for at least 5 days before they could take the first pill.
Why? Is there a biological reason, or is it just bureaucracy?
It's mostly just how the studies were designed, but it creates this huge logistical hurdle. I mean, think about it from the patient's perspective. If I prescribe apixaban, you take a pill and you go home.
Easy enough?
If I prescribe dabigatran, you either have to stay in the hospital for 5 days to get shots, or I have to teach you how to inject yourself in the stomach at home for a week.
I know which one I'm choosing.
Exactly. That's why apixaban and rivaroxaban really dominate the market. The single drug approach is just so much easier for everyone involved.
So why does warfarin even still exist? Who are we still using it for?
Warfarin is still king for a few niche groups. If you have severe renal failure, for instance, DOACs can accumulate and become dangerous. Warfarin is cleared by the liver, so it's safer there.
Got it.
And for patients with antiphospholipid syndrome, that's an autoimmune clotting disorder, DOACs have actually been shown to fail in some studies, so warfarin is still better for them.
But warfarin is such a pain to start. The sources talk about bridging. Can you explain that? It sounds more like engineering than medicine.
It's like a relay race. That's the best analogy. Warfarin is a very slow runner. When you take the first pill, it takes about 5 days to actually thin your blood. In fact, for the first 48 hours, it can bizarrely make you more prone to clotting.
Wait, the blood thinner makes you clot?
Temporarily, yes. It depletes some of your body's natural anti-clotting proteins first. So you need a fast runner to carry the baton while warfarin warms up. That fast runner is heparin, or enoxaparin, the injectable. So you give the shots, the fast runner, and the warfarin pill, the slow runner, at the same time.
They're running side by side.
Exactly. And once warfarin gets up to speed, which we measure with the INR blood test, once that INR is between 2 and 3, then the fast runner can drop out and warfarin carries the baton alone. That overlap is the bridge.
That is a great analogy. But it really highlights why everyone wants to move away from it. Keeping track of 2 runners just sounds exhausting.
It is. It's very high maintenance.
Let's pivot to a couple of special scenarios. The sources highlight cancer and pregnancy. I'm assuming the rules change there.
They do. Cancer patients are what we call hypercoagulable. Their tumors release factors that just trigger clotting. For a long time, the rule was LMWH shots forever.
So you have cancer, you're going through chemo, and you also have to give yourself a shot in the belly every single day.
It was miserable. But the good news is that recent studies have shown that DOACs like apixaban work just as well for most cancer patients. So now, thankfully, most of them can just take a pill.
That's a massive quality of life win.
It's huge. The only caution is really with GI cancers like stomach or esophageal. DOACs can sometimes irritate the lining and cause bleeding there, so for those specific patients, we might stick with the shots.
And what about the safety net? We're thinning the blood. If a patient falls, hits their head, how do we reverse this? I know vitamin K for warfarin. What about the new drugs?
That was the big fear when DOACs first came out, the whole no antidote thing, but that's been solved. For dabigatran, we have adarcrizumab. It's a monoclonal antibody that just grabs the drug and turns it off, works in minutes.
And for the popular ones, apixaban and rivaroxaban.
We have undexanet alpha. It's basically a decoy molecule. It looks like the clotting factor the drug is trying to attack. So the drug binds to the decoy instead of your body's proteins. It's very clever, very effective, and very expensive.
Good to know it's there, though. Now, I have to ask about IVC filters, the little umbrella in the vein. 10 years ago, it felt like everyone got one. Now, the sources seem pretty chilly on them.
It's a classic case of a good idea in theory that just failed in practice. The idea is so simple. Put a little metal net in the inferior vena cava, the main vein, to catch any clots before they hit the lungs.
Makes total sense. So why is it bad?
2 big reasons. 1, the filter itself is a foreign body, so it can actually cause clots to form right there on the metal struts. It becomes a clot nest.
So the solution becomes the problem.
Exactly. The data showed that while they might reduce PE, they actually increase the overall rate of DVT. And second, people just forget to take them out. A temporary filter gets left in for years, scars into the vein wall, and becomes impossible to remove.
So what's the verdict now?
Use them very sparingly. Only for patients who absolutely cannot take blood thinners, like someone with an active brain bleed, or maybe someone who keeps getting clots despite being on meds. And if you put one in, you make a plan to take it out.
Got it. Okay, so we've stabilized, we've treated. Now we're looking at the long game. The patient survives the PE. What happens next?
We have to decide duration. Is this 3 months, 6 months, forever? We used to rely on this idea of provoked versus unprovoked.
Right. If you broke your leg and got a clot, that was provoked. Treat for 3 months, then stop.
Because the broken leg heals, so the risk is gone. And if it was unprovoked, it just happened out of the blue, we assumed you had some underlying tendency and we treat you indefinitely. But the data just doesn't paint that picture. The ESC found that many of those so-called provoked clots have recurrence rates almost identical to the unprovoked ones after you stop the medication.
So focusing on the cause was kind of distracting from the real issue.
It was distracting from the real metric, which is the statistical risk of it happening again.
Okay, so they've reorganized everything into 3 new tiers: low, intermediate, and high risk.
That's the new framework.
And I was looking at this low risk category, and it's incredibly exclusive.
It really is. To get into that safe zone, and we're talking less than a 3% chance per year of another clot,
Yeah.
you basically have to have survived a catastrophe, major trauma or major surgery. That's it.
Because in those cases, you can confidently say the event caused the clot, and once you heal, the risk is gone.
Precisely.
So that pushes almost everything else into the intermediate or high-risk buckets.
And that intermediate bucket with a 3% to 8% annual risk is where I think the biggest aha moment is.
This is where we find things like minor surgery, a hospital stay for an illness, or even pregnancy.
Don't forget long-haul flights or using estrogen contraception. And here's the crucial insight.
Okay.
If a minor trigger, like a 6-hour flight, is enough to cause a clot in your body, that trigger isn't acting alone.
It's the straw that broke the camel's back.
Exactly. A healthy system handles a flight just fine. So if you clot, it suggests you have some kind of underlying, maybe permanent, tendency to clot.
Which is why those are now in the same risk category as patients with no identifiable risk factor.
It levels the playing field. The mystery clots aren't so mysterious anymore. They just have the same statistical weight.
And then you have the high-risk tier.
Right, over 8% recurrence per year. This is really reserved for active cancer or conditions like antiphospholipid syndrome.
Things that create a constant state of risk.
A persistent risk factor, yeah.
So this recategorization must totally change how long people stay on anticoagulants.
It moves the goalposts entirely towards safety. In the past, a provoked clot from, say, minor surgery.
You'd maybe do 3 months of therapy and be done.
Right. Now, the recommendation for that same patient is to consider oral anticoagulation without a specific end date.
Indefinite blood thinners. For a clot triggered by something minor, that's a heavy pivot. CTEP.
Chronic thromboembolic pulmonary hypertension. This is the nightmare scenario. For about 2 to 4% of patients, the clot doesn't dissolve. The body fails to clean it up. Instead, the clot transforms into scar tissue. It becomes like concrete lining the pulmonary arteries.
So the patient is just permanently short of breath.
Yes. And eventually, their right ventricle fails from trying to pump against that concrete wall, and pills won't fix this because it's not a fresh clot anymore.
So, what's the fix?
Pulmonary thromboendarterectomy, or PTE, it is one of the most intense surgeries in modern medicine. They open the chest, put the patient on bypass, and then they cool the body down, way down, to about 20 degrees Celsius.
They induce hypothermia.
Deep hypothermic circulatory arrest. They actually stop the heart and turn off the bypass machine. The patient has no circulation, no blood flow to the brain.
For how long?
They have about 20 minutes of arrest time for the surgeon to go in and surgically scrape that scar tissue out of the arteries. Then they turn the pump back on, warm them up, and restart the heart.
That is absolutely wild. They are, for all intents and purposes, dead on the table for 20 minutes.
Controlled death, essentially. But the results can be miraculous. Patients who are wheelchair-bound can go back to hiking. It's curative.
That is an incredible note to end on. Thanks for walking us through the deep end of the pool on this one.
Anytime. It's a fascinating topic.
We'll see you all in the next deep dive. Stay curious.